Welcome to the patient journey and addressing optimal VTE treatment pathways. In previous sessions of the VTE Heartbeat series, we provided an overview of VTE, discussed specific assessments and considerations for patients with VTE, as well as selecting the right anticoagulant for a typical patient with VTE and patients with more complex conditions, such as during treatment for cancer or with obesity. Today, we're going to focus on the patient journey, starting with the time of diagnosis of VTE in a variety of settings, moving into VTE selection based on a particular care setting, and discussing side effects or complications a patient with VTE can experience along the way. We will also discuss transitions of care, which are critical time points in a patient's journey, during which miscommunication or lack of communication altogether can not only negatively impact patient satisfaction, but also patient outcomes. As we get started, I want to mention that this series is supported by an educational grant from the Bristol Myers Squibb and Pfizer Alliance. Recommendations and opinions presented may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA. The AHA does not endorse any product or device. I'm Dr. Erica Shore, Associate Professor and Chair of the Adult and Gerontological Health Cooperative at the University of Minnesota School of Nursing. And joining me today is a distinguished multidisciplinary panel.
Hi, my name is Tara Leck. I'm a clinical pharmacist and Director of Anticoagulation Services and Stewardship for Beth Israel Lahey Health.
I'm Arthur Allen. I'm a clinical pharmacy specialist and anticoagulation program manager at the VA hospital in Salt Lake City.
I'm Jeffrey Barnes. I'm a cardiologist and vascular medicine specialist at the University of Michigan.
Well, let's jump right in. When we think about a patient's first diagnosed with a DVT or PE in the ED or the hospital, how is that initial anticoagulant selected? Jeff?
That's a great question, and it tends to be selected by whoever is caring for that patient. So in the ER, it's usually that ER physician or advanced practice provider. In the hospital setting, it's probably the hospitalist or whatever clinician is caring for that patient. And it tends to be selected based on sort of the sense of, is this somebody who's going to need to be in the hospital? Or is this somebody who we're planning to send home? If this is somebody who's considered to have a low-risk DVT or PE, for whom maybe out of the emergency room they don't even need to be admitted, that's a great opportunity to use an oral-only strategy, which would use either apixaban or rivaroxaban to treat that patient, avoiding any parenteral anticoagulant. But if that's a person being admitted to the hospital, whether it's because you might need to do a procedure or just because they have other medical conditions, we tend to use parenteral anticoagulants, things like low molecular weight heparin and unfractionated heparin, so that we have a little bit more sense of control over on and off with the anticoagulant, depending on how their course goes.
So could you give us some sense of who is involved in that decision-making process?
It's an interesting question. We actually did a recent qualitative study where we asked hospitalists, ER clinicians, and even proceduralists sort of who was making these decisions. And the sense was everyone who made the decision thought they were making it for somebody else. So the ER clinician thought they were choosing an anticoagulant because that's what the hospitalist or the proceduralist wanted. And the hospitalist said, well, I'm just continuing what the ER does. The proceduralist said, hey, look, it doesn't matter to me. I can do these procedures on sort of any anticoagulant. And so I think there's a real opportunity for these groups to come together in a coordinated fashion and figure out what is the best anticoagulant for different types of patients so that we make sure everyone's getting the most efficacious, safest therapy for them. More coordination up front will make it easier for that ED clinician or that hospitalist to make that right choice.
Those are great points, Jeff. Tara, I'll pose this question for you. What is the potential role for clinical pharmacists to engage in the anticoagulant selection process for patients that are diagnosed with an acute DVT or PE, either in the ED or the hospital setting in general?
Great question, Erica. I think it's really important to involve our pharmacy colleagues up front in the selection of the proper anticoagulation agent for our patients that present with acute VTE. Pharmacists are poised and ready to evaluate your patients for which medication is going to be most appropriate. So they're going to look first to see if a DOAC is appropriate for your patient. Are there any contraindications that might preclude use and draw your clinician to have to use, warfarin with a low molecular weight heparin bridge? We're also going to have them do a thorough medication reconciliation. So they're going to be able to evaluate not only the prescription medications that your patient takes, but also the over-the-counter and herbal remedies that might influence or impact your choice of anticoagulant. And then finally, really thinking about the education. This is probably one of the things that pharmacists can do best for your patients, especially in the ED, where we know that this might be the only chance they get to really talk about the medication, how to take it, any potential side effects to watch out for, and then when to follow up with their provider. So I think including them as part of the care team is vital to making sure that we get those first steps right.
That's helpful, Tara. Jeff, what are some other strategies that can be implemented to help ED and inpatient providers select the most appropriate anticoagulant for a patient at the time of diagnosis?
I think there are 3 different things that you can think about using to help your clinicians make the most evidence-based selection of anticoagulants. The first is creating order sets that encourage people to use better anticoagulant choices. So, for example, if you have an acute DVT or PE order set for an admitted patient, have a low molecular weight heparin be the preferred anticoagulant, with unfractionated heparin being the alternative. That way we can get people on a more reliable anticoagulant that's more quickly therapeutic and doesn't have that same risk of overshooting or developing heparin-induced thrombocytopenia. The second option you can use is figuring out ways to support patients who are going to be prescribed the oral anticoagulants so that you're confident they're going to be able to afford and obtain those medications when they go to that outpatient pharmacy. That might be giving them a prescription drug card or connecting them with a social worker or other medical support person who can make sure that they can afford it. You may ask your pharmacist to run a check to see what their copay is going to be, but something that's going to help you really be confident that that patient can afford and pick up that medication when they go to the outpatient pharmacy. And then the third thing to think about is whether or not a starter pack is the right thing to use, or whether you want to be prescribing the usual pills in a bottle. And starter packs can be great, especially if you're using an oral only strategy where the dose is going to change at either 7 or 21 days. But you have to be aware, most of our commercial pharmacies, outpatient, are not stocking them on the shelves. So there may be a day or 2 delay until they get them. And you don't want to order a starter pack that an outpatient provider might accidentally refill for month 2 or month 3. So unless you're going to hand somebody a starter pack right out of the ED, it's probably better to prescribe them just the standard dose of the medication. That way, you know the pharmacy has it on the shelf. They can get it the same day. And then the outpatient prescribers can go ahead and refill at the appropriate normal dose. I think those are 3 really effective strategies to use.
Thanks, Jeff. What about we think about a diagnosis of a DVT or a PE in an outpatient setting? Arthur, who might be responsible for anticoagulant selection in that scenario?
Yeah, I think it actually is, pretty similar to what Jeff was saying, that it depends on the model of care, and it could be the ED provider, it could be the primary care provider, it could be a specialist in an outpatient clinic. But I think what's key that he touched on, and I was going to mention this as well, really tagging on to what Tara had to say, is that if we can work smarter, not harder, in this setting by utilizing standardized order sets and protocols. In today's electronic health records, you can work magic, and you can literally guide providers down the path that they need to go down without having to have these kind of one-off conversations, one patient at a time. So if it's VTE, we go this way. If it's AFib, it's this way. If the patient is renally impaired, then we have split offs. If the patient has cancer, we might think. So you can do a number of different things with different order sets, and that applies really across the spectrum of a facility or a health system that has an electronic health record, regardless of which provider type is using it.
So you touched on some of the points about how clinical pharmacists can support patients and clinicians. Do you have other ideas about that?
Sure. So that's the getting the drug to the patient at the time of a diagnosis. We don't want to be a speed bump. We don't want to be and we don't want to be obstructionary. We want to create processes that allow that to happen at 2 a.m. in the morning, that and happen correctly, right? But then the follow up from that in the outpatient setting is what is key. So for as using my search as an example, every patient that gets prescribed an anticoagulant gets managed through the anticoagulation service. We see our service not as a non-formulary request for the medication, but rather as a specialty service like any other that is being consulted to engage in our specialty, but the drugs being simply tools in the tool belt. And so for us, every patient gets consulted to us. We evaluate, we push back. We at the time of that consult, one of the most important things we do is at the time of that consult, we evaluate the case to determine if it's the right thing. As an example, a lot of ED providers or different specialists who don't specialize in this will just kind of see a clot and treat them all the same. And where we can come in and say, no, wait, that's an isolated distal DVT. You have some options, or that's actually a superficial venous clot that may not even need to be treated at all. We might be warm compresses and anti-inflammatories. And so having us jump in at that point and make sure that what got started is the right move. And then, as Tara pointed out, the inpatient setting, providing the education, providing the expectations, and then ensuring that important touch points take place. Like, who is owning VTE duration decisions? When is that happening? Is somebody at the 3-month mark saying, are we done or do we need to keep going? If not, who's playing that role? In my facility, it's our services playing that role. In a lot of facilities, everybody assumes somebody else is playing that role, and the truth is no one is.
Erica, can I just build on something Arthur said? Because again, I think he highlighted 3 potential roles for clinical pharmacists. The first is engage a clinical pharmacist when you develop your order set. Let's make sure that you're recommending the appropriate meds at the appropriate doses. Second, have a clinical pharmacist available for those point of care calls. I have a patient I need to treat right now, and I'm not sure what to do. Who can I reach out to get some advice? But then third, and perhaps one of the biggest roles, is after I've prescribed that medication, who's going to make sure as a double check that I did the right thing and be a resource for follow-up? I think all 3 are really great roles for clinical pharmacists to support our patients with DVT and PE.
They're great points, Jeff. Tara, I'm going to discuss a specific scenario of a patient experiencing a side effect. So a patient who recently started anticoagulant therapy and they're experiencing bruising and bleeding. Who should they be contacting?
So their healthcare provider, oftentimes they will call the clinic first because that's the number they have and that's the person that picks up the call all of the time. And they know they're going to get through. But knowing, and we train our clinicians to look at the type and severity of the bleed. So if it's a gum bleed or an increase in bruising, we're going to let their PCP know and schedule follow-up. But anytime they're reporting, blood in their stool or urine, or, they're feeling hypotensive, then we're wanting them to go to urgent care or emergency care, depending on the event, so that they can be seen in real time for those concerns.
Okay, so helpful to differentiate the symptoms that are being experienced as to who you contact based on the symptom. What options exist to help patients reduce their bleeding risk while they're on the anticoagulant?
So there are quite a few things that we can do. And the beauty, if you utilize an anticoagulation clinic or, have, these clinical pharmacists looking at your patient, is that we can try to do some of these things before the bleeding happens. But unfortunately, we know that most of the times it takes the bleeding event for people to take a closer look. So when that does happen, we want to be doing a complete medication review, like we talked about earlier, and seeing if any new medications or, over-the-counter products were added or stopped that may be causing these issues. Again, looking at aspirin if they're on it, seeing if they need to be on it. We're also going to do another check of their, if they're on a DOAC, we're going to look at their renal function. We're going to make sure that the dose of DOAC that they're on is appropriate for them. And with VTE, we know, especially in the acute setting, we're using standard doses. We're not ever dose reducing in the acute setting for VTE. So if it is someone that has acute kidney injury, then we need to, rethink the treatment plan to see, can we continue this or do we have to think of other options? And then, just, going over the education and monitoring with the patient and having those discussions if, we're going to be continuing use.
If I could jump in there just real quick on risk mitigation, we often use CHA2DS2-VASc scores in AFib patients. We use HAS-BLES scores. We use these bleeding scores, and I think that folks tend to look at them as like, well, should I anticoagulate it or not? And that's not what they're designed for. They're designed to identify, risk factors that can be mitigated. And speaking specifically to pharmacodynamic interactions like aspirin and NSAID, I just completed an interesting project looking across 400,000 anticoagulated patients in VA on patients on DOACs, and found that even in VA, where we've had anticoagulation services since I had hair, I mean, a long time, we've had uh, strong practices with DOACs from jump since they came on the market. The range in sites and their use of antiplatelet therapy. I know Jeff has been working in this space too. We had sites with site level antiplatelet use over 40%. And the best sites, less than 9%. We had sites with over 11% of patients on NSAID therapy at a VA where we've been doing this for a long time. The best sites were closer to 0.5% of their population prescribed NSAID. And I bring this up only to say there's a lot that we can do. There's a lot of opportunity for stewardship initiatives here. And if we're spending all of our time checking boxes of monitoring and, doing good patient education, but we're rocking 40% of patients on antiplatelets, our efforts could be spent elsewhere.
Thanks, Arthur. So thinking about a patient in these different clinical settings, so we think about transitions of care and handoffs that are happening as a patient moves through these different care settings. And these are periods of high clinical risk. Arthur, what types of processes have the VA implemented to reduce those risks for patients that are newly starting anticoagulant medication?
It's a great point. And across the VA, there are different models of care. Some like my service kind of put their arms around anticoagulated patients and keep them. Others put things in place to allow kind of more peripheral oversight with primary care providers, maybe primarily in charge. There are for transitions of care specifically, we we can be we can create our own chaos by saying, I got to know when a patient went in the hospital. I got to know when a patient came out of the hospital. I got to know when a patient went to the care facility, just in case there's anything I need to know about. The better approach is to put things in place that are that make you aware when you need to be aware and not bother you when you don't. And so we have a strong relationship with our inpatient clinical pharmacists at the VA. They know to communicate to us things that are relevant for admissions and discharges. When patients go to long-term care facilities, we have a method of kind of tracking those for when they kind of return under our care, making and ensuring that any necessary recommendations are passed off. And then overall, managing patients overall, the VA instituted some time ago now a population health approach that basically allows technology to watch patients in the background, not have us create a bunch of busy work to make sure that there's not something we need to know, but then present to us things that may be of clinical importance so that we can focus our attention only on those things which may be clinically important and kind of ignore the rest and let the patients go without burdening them for unnecessary visits and labs. So it's created a good way for us to develop. And we've published a number of works on this. Jeff has actually done this as well, and developed this in Epic and done some publications in the University of Michigan system as well, to allow us to essentially ensure oversight without working ourselves to death.
Do others have approaches that they take in their care settings to reduce risk for patients who are just starting anticoagulant therapy?
As Arthur mentioned, we try to have our inpatients reviewed by one of our inpatient clinical pharmacists. And on the outpatient side, we have built a dashboard so we know when people are prescribed an anticoagulant, and it flags for us if there may be some sort of off-label use or some combination of anticoagulant plus aspirin use that could put a patient at increased risk for bleeding. I also think use of order sets is a great way to sort of encourage people to use appropriate dosing. We see a lot of people using AFib dosing for VTE. We see people prescribing the starter packs because they hear starter for AFib. So using order sets that can really direct people to using the right drugs is a really effective strategy.
Yeah, and at our system, we have actually tied our referral for the anticoagulation clinic to our starter packs for VTE to try to drive any of those new discharges, especially from the ED, to go straight to the clinic, because we don't have as integrated of a system where all of the anticoagulant prescribing is flowing into our clinic. But this helps us to capture that. And then, we're also working with our EDs regularly and our hospital medicine teams to try to figure out ways to reach and empower the patient and help them engage in their care. One quick little thing that we had done is, creating a handout for patients that they get. It's called Know Your Meds, where the meds stands for, have you had a medication review? Did you receive education? Did you discuss about your disease state and no future planning? And then the S is, have you scheduled a follow-up? And do you understand the reason for your follow-up? Because we know a lot of times they get a list of future appointments, but if they're not actually sure why they need to go, they're more apt to cancel. So we're really trying to engage them in their care up front.
Thank you all. In this discussion of the patient's journey, we've highlighted the individualization that exists in the patient's journey as opposed to a one-size-fits-all approach. Treatment selection must factor in discharge disposition, drug cost, patient resources, and individual bleeding risks. Some strategies to ensure appropriate anticoagulant selection and reduce risks are medication reconciliation, order set development, and implementation. And of course, a key component of all of this is the multidisciplinary collaboration and communication across all the points of care in the patient's journey. So I want to thank you to all of our panelists and the American Heart Association. This series is available through major podcast platforms. To claim credit, visit learn.heart.org.